It's been a big year already in the pharmacy space with an FTC settlement from Cigna's PBM Express Scripts, PBM reform making its way into law, IRA price negotiations for specialty drugs like Eliquis taking effect, and a rural transformation program looking to expand the scope of practice for pharmacists. To talk through the House RX approach to specialty pharmacy, medically integrated dispensing, and all of this regulatory swirl, we've got two pharmacist leaders from the team, Denali Cahoon and Tamiko Yamatani. Could we start with some introductions from you two? Maybe to Denali, we'll start with you.
Sure. Thanks so much for having us on the show, Martin. We appreciate it. Yep. So my name's Denali, and I'm the Chief Operating Officer, Chief Pharmacy Officer at House RX. Basically, part of my job is just to hire great people like Tamiko. But mainly it's, our goal, our vision at House RX is to really shake up the specialty pharmacy space and to make it a much better experience for patients and a better experience for providers. So if that's what we're trying to do, I just have to put in place the people and really the processes in order to make sure that we deliver on that mission and consistently have a better experience day in, day out for every single patient we touch.
And my name's Tamiko. I'm our VP of Customer Operations and report to Denali. Also a pharmacist by trade, as Martin mentioned, and focus on our two teams, program management and implementation. I've spent the majority of my career implementing specialty pharmacy programs, starting with hospital systems, community practice, and now in medically integrated dispensing. So very excited to be here, Martin.
Thank you both so much for your time today. So where I want to start is for folks who aren't familiar with House RX and medically integrated dispensing, could you talk a little bit about the business and also what that medically integrated dispensing model is?
Sure. I'll take that one. At House RX, we're really empowering community practices, particularly community specialty practices, think oncologists and rheumatologists, to essentially operate their own specialty pharmacy services for their patients and be able to dispense medication directly to their patients. This is in contrast to the more traditional specialty pharmacy model where patients are essentially the only other option is to use some like large big box mail order specialty pharmacies. So we're building medically integrated pharmacy services, and I'll talk a little bit about what does that mean? What is medically integrated? Really, it's about embedding the pharmacy team and really patient support, really as far upstream as possible. Basically making it so that the pharmacy services are part of the medical care team, and that it really is very different than how pharmacy is traditionally delivered and how historically, pharmacies actually serve patients. Really what normally happens is that the medical provider, right, they send a prescription out to a pharmacy and the pharmacy dispenses that medication and they're supposed to be sort of deploying their clinical judgment about the prescriptions and really they take accountability for making sure that they're dispensing medications accurately, but they don't have the information to do that. And so by bringing pharmacy services as far upstream as possible as part of the care team, it's a fundamental shift in how pharmacy is practiced. And I guess really critically, some of the features that would distinguish it from this like traditional pharmacy model, one is just access to information. And it feels really obvious when I talk about it, but it is kind of groundbreaking because it isn't how pharmacies operate. But when we're part of the team, when we're medically integrated, we have access to the EHR, so to the electronic health record. And so you have all the information that you need then to effectively do the role, all the clinical information, et cetera. And also, because the pharmacy is part of the medical team, the pharmacists and our technicians, we're actually documenting in that same spot in the EHR. So not only do we have the clinical information we need, but then the providers and the rest of the care team, they have all of the information as well. And they have the complete picture about what's happening with the patient. So a lot of it is about access to information. And then also, there's an element of, I guess, real-time communication. So, everybody who's involved in the patient care, the pharmacists and the provider and the nurses and everybody else, you're able to communicate real time in the EHR and really just have, I guess, shared accountability for helping the patient to get the best possible outcomes. I think that medically integrated pharmacy, it's really, I think it's particularly effective for specialty pharmacy, which is area where HouseRx plays, right? We take care of specialty patients, oncology patients, rheumatology patients, et cetera. And, specialty pharmacy, especially pharmacy at its core, and I've spent my whole career in different sort of areas of specialty pharmacy. But what it's designed to do is, we're supposed to provide this like very high touch pharmacy support to patients. And the patients have, serious chronic conditions and they're on these complex medications. They're very high cost medications. And this model of pharmacy care is designed to, I guess, help the patients to have better outcomes. And, basically when you think about specialty pharmacy, everything that is required to really successfully practice specialty pharmacy, it's made like so much easier by actually being embedded into the clinical practice. I always try to think about it as like, if you're practicing pharmacy the traditional way, it's like trying to do something with your hands tied behind your back. You have your hands behind your back right now. But if you had your hands tied behind your back, it's like, it's much harder to do it and it's much slower. You can do it, but you're not going to get the same results. So by being medically integrated, we basically make it that much easier. Some of the functions, if you want me to be, sort of more specific here,
Yeah.
specialty pharmacy, it's about access. Like if you break it down, it's access. It's getting patients onto the drug as quickly as possible. It's about adherence, right? Keeping patients on that drug. And then it's about outcomes. We want them to have like the best possible outcomes on these medications because they are high cost. You don't want to like waste that money. And so, access, getting patients onto drug and doing that really quickly, it's really about navigating, the complexities, of course, of our health system. So in particular, prior authorizations and then, navigating financial toxicity, financial assistance. And those things are, again, so much easier if you're a part of the practice. So prior authorizations, like what you have to do there is just like provide the clinical justification for why a patient has to be on medication. Well, you can't provide the clinical justification if you don't actually have access to the clinical information. So you need the labs and you need the imaging and you need the chart notes. So by being an EHR, we can do that faster. We can get it approved more quickly. And, financial conversations, those are, one, they're complex, but they're also like really emotionally fraught, right? You're talking to a patient who is sick and they're being told that they're going to be responsible for thousands of dollars out of pocket. And they're trying to make the decision of like, oh, do I actually take this medication or do I basically like pay my mortgage? And so those conversations are difficult and the process is not designed to be easy. So there's like a lot of navigation between the provider and the pharmacy and the patient, documents that need to be signed and a bunch of hoops that you need to jump through. So again, that is much easier if you're part of a trusted member of the care team. We try to train everybody, ourselves included, and of course, our parents and our grandparents, like not to fall for scams and give away their social security numbers and their income information. But all of that is required to do this. So again, being, part of the trusted care team is important. And then there's everything clinical. Everything is made easier, right? So if you're talking about adherence and side effect management and dose reductions and making sure it's an appropriate therapy, it's all much easier when you have the right information and you're able to communicate really like seamlessly amongst members of the care team. Do I have you convinced yet?
Oh, yeah, no. I mean, this is like a great form of the argument. I think one conversation that's very salient right now is around affordability and drug costs. I think most people are familiar with, the ratios of like specialty drugs are X percentage of the drugs prescribed, but Y percentage of the spend. I'm curious for you two, if I could get you two to weigh in a little bit about how you all think about affordability internally and what that means. Because I think, there's the price that the drug or the patient pays, but there's also the medical part of it. Like, are they taking the drug? Is it effective? Are they, is compliance? And so I'd be curious to kind of get the HouseRx view on how you think about costs and affordability. Yeah.
It's a good question. It's complex, obviously, because the issue of affordability is always very different depending on what lens you're taking. We at HouseRx, we always try to be incredibly patient-centric and also very provider-centric. But we also have partners, right? In order to be effective in the pharmacy industry, you have to partner well with manufacturers. You have to partner well with payers. You really have to be thoughtful about really all of the way that we operate and how it's going to impact everybody in the ecosystem, basically. But thinking, I think, first, obviously, from a patient lens, because always first and foremost, when a patient thinks about affordability, it's simply about what is their out-of-pocket cost, right? They are not thinking about the impact to the greater healthcare system. They just want to know if they're going to be able to get into this medication that is going to either improve their life or maybe, not to be dramatic, but like save their life. And so, especially medications that cost, 5, 10, 15, many thousands of dollars per month, realistically, patients aren't paying out of pocket for these medications. So this isn't, the type of discussion that we might be having about, trying to get the lowest cash price for a specific prescription. This is really about navigating the insurance system, those prior authorizations, et cetera. So when we, again, think about affordability, the keys to patient affordability are it needs to be approved by their insurance company. And it also, then we need to navigate those, financial hoops that I talked about. But in order for it to be approved, this is where, sort of the incentives end up getting aligned amongst a lot of the different parties because, to get approved, most often it has to be on the payer formulary. And to be on the formulary, right, the payer has negotiated rebates and discounted pricing. And also the patient, they have to have met the utilization management criteria. So, step edits and trying and failing lower cost alternatives first. So, and especially pharmacy is designed to make sure that the therapy is appropriate, right? We're not just trying to get any medication approved. We're trying to get the right medications approved and that the patient does meet that criteria. So, a good specialty pharmacy ends up aligning those incentives because those tools, formulary management and utilization management, are meant to constrain costs for the system. And then, the way that HouseRx, the way that we think about, in particular, again, I always sort of preach to the choir here about medically integrated dispensing, but medically integrated dispensing can do this better than other models, especially pharmacy care, this like thinking about constraining costs. Because when you're working, again, hand in hand in lockstep with the provider and with the patients, some of the things that we can do really well are, avoidance of waste, right? So making sure that we're not, when the patient goes in and the provider does a dose reduction and so they only need half as much therapy, we know that immediately because we're part of the care team. And so we don't sort of over dispense. We don't over dispense if the patient's therapy has been put on hold or, if the patient's deceased. These are things that especially pharmacy doesn't get a flag and a notification when these things happen. And so we avoid waste in that way. We also, this model is much better at mitigation of really serious adverse events. Think hospitalizations. That all adds like a ton of cost to the system. And then just generally by having better outcomes, right? If a patient is having less flares of their autoimmune condition or, less disease progression for their, oncology therapy, those all reduce cost to the system. So there's plenty of data to support that medically integrated settings, whether it's in a community practice or, hospitals have been doing this for a very long time, deploying medically integrated pharmacy, that it ultimately reduce sort of the total cost of care. So we do believe that the model that we deploy, it definitely impacts patient affordability, but just generally cost across the whole system.
So on the regulatory front, taking a step back for a second, right now, a lot of specialty pharmacy is integrated with PBMs. And so you mentioned, it's going to a specialty prescription is ending up at a mail order specialty pharmacy. It's generally vertically integrated with the PBM. I think that the argument that the PBMs make is that that's an effective way to control costs. Some of the regulatory actions we've seen recently, I think, have provided some evidence, perhaps to the contrary, that's been an effective cost control. And so I just want to talk through some of these recent regulatory developments. The first one was the Express Scripts FTC settlement, and I'm curious for you two to kind of weigh in and for those of us who are less in the weeds on what's going on with this, what does that mean for independent and medically integrated pharmacies like you all?
Yeah, I'll take that one. And there is, to your comment, a lot going on in the regulatory front. And essentially, the entire formula, reimbursement minus cost equals margin, is under a microscope. And for the first time, it's really targeting the biggest players in the systems, the PBMs and the manufacturers. They're squarely in the spotlight. So on the Express Scripts FTC settlement, the timeline here started in 2022. And just this month in February, the FTC released its settlement details with Express Scripts. So on paper, there's about 10 commitments in the FTC order that Express Scripts has agreed to. But those 10 can really be boiled down to three main themes. First is cost reform and pricing transparency. So it's an end to Express Scripts favoring high-priced drugs, particularly the ones that come with hefty rebates, when a lower cost alternative exists. It also explicitly states that the patient cost sharing must be of the net price, not the list price. So unfortunately, prior, that wasn't explicit. And so even though, the net price could have been something, inclusive of rebates, patients were taking and being charged a percentage of the net price there. The second, expanded and standardized access. So that's really the second theme. And so the entire investigation really started with a focus on insulin. So the order pushes for broader access to programs like insulin savings, and requires standardized offerings. So the message being, it has to be consistent. Fewer opaque carve-outs, more predictable benefit structures, and the sponsors and the dispensers are supposed to be clearly informed about what's available. And then the third main theme is really a structural change. So Express Scripts Group Purchasing Organization, Ascent, is being reshored as it was operating in Switzerland. And so purchasing activity is shifting back to the US. So really, to answer your question directly, it's kind of the bigger story that we all should be focusing on, is that for years, vertically integrated PBMs justified consolidation under the banner of cost reduction. Their argument was always scale lowers prices, integration drives efficiency, rebates create savings. And the FTC effectively said, show us your math. And now the tide has shifted. So, the conversation's no longer about theoretical savings at scale. It's about price clarity, patient affordability, provider viability, and whether the economics actually flow through to the people at the point of care. So that settlement doesn't just end that debate of vertical integration. It really does reframe it. And so the industry is now being pushed to move from defending cost structures to providing value. And that's just a very different position to be in. Ironically, that proof of value standard, as Denali already described, is where medically integrated dispensing already lives. It's already at the center of the clinician and the patient. And so, a lot of the themes that are in the Express Scripts, FTC settlement also exist in an appropriations bill.
Yeah, so there was a lot in the appropriations bill and PBM reform. One of the things that struck me about it was strengthening of the any willing pharmacy provisions. This is one of those things that if you're kind of outside of the PBM world, you're like, that sounds very vague. Like, I don't know what that means. But it caught my eye because when I was talking to your CEO earlier in the year, he mentioned that the any willing pharmacy provision was an important part of your business. I'm wondering if you can explain what the any willing pharmacy provisions are and why it's meaningful, and what the approps bill did for the any willing pharmacies provision.
Yeah, absolutely. And the scope for the Consolidated Appropriations Act of 2026 is focusing on Medicare Part D. So it's just important to clarify. It boiled down to two massive things. And, the major shift, and quite honestly, the one that I think hasn't gotten much airtime, is how it rebalances the relationship between PBMs and dispensers through this any willing providers. So As you've mentioned, we've had a federal any willing provider rule on the books for years. So in theory, if a dispenser agreed to the same terms as everyone else, they had to be let into network. In reality, CMS couldn't and wouldn't enforce it. And so there was always this unanswered question of who decides what reasonable terms and conditions are. And so now that question really will be gone. It doesn't just suggest fairness, it really does codify it. So it explicitly says that participation terms must be reasonable and relevant, but more importantly, it puts CMS in the driver's seat to define what that means. So that's a massive shift. CMS is now expected to evaluate whether reimbursement rates actually cover ingredient costs and operating costs, whether the dispensing fee makes sense, whether quality measures are appropriate, and whether audit tactics are abusive. And then, the next part that also really changes the game is that dispensers will now have a formal pathway to go to CMS and say, hey, these terms aren't reasonable. And CMS isn't allowed to just shrug anymore. They can investigate, they can issue findings, they can direct plan sponsors and PBMs to fix it. And so, really, what has happened over the years where we already had this any willing provider statute is that CMS leaned on this Part D non-interference clause. And so they basically said, we're not allowed to interfere with contractual disputes. And so that hands-off approach is over. CMS isn't just really like overseeing the system anymore. It's expected to step in and it's being asked to referee. And all of that, it's phased in the bill. So all of that will truly start in 2028.
And the reason, obviously that we think that this is so important, everything that I described about medically integrated dispensing and how that's better for the patient and better for the provider, that all rests on the providers being allowed to dispense medication directly to their patients. So it's why we think that so much of this is so critical and important. We want patients to be able to choose this model of care and not to be required to utilize, a big box specialty pharmacy.
It sounds like a big win for more competition, which I think is good for patients. It's good for the PBMs, obviously, or in the long run, because they'll have to compete on the merits rather than these sort of anti-competitive, and better overall for taxpayers, because the competition is, I think, ultimately what ends up driving down costs in these things. The IRA, I'm curious for your views on the IRA. So we're now going, I think it's the second year of negotiations, but the first year, 2026 is the first year where the price negotiations are taking effect. For those of us, again, who are less familiar with pharmacy pricing, what's the significance of the IRA for some of these specialty medications?
Yeah. And again, IRA focuses on Medicare lives. And it's already delivered meaningful change in Medicare Part D. It was actually started back to 2022. We've seen since then no out-of-pocket cost for vaccines, insulin capped at $35 per month, the elimination of the donut hole, which is a crowd favorite, and a hard annual out-of-pocket cost for patients at $2,100. So, that's real relief for Medicare beneficiaries. There's also been implemented now copay smoothing. So that's spreading that to $2,100 across the year so that patients aren't hit with a financial wall in January. The implementation of that hasn't been seamless. PBMs, of course, have found ways to operationalize it creatively, but just from a patient planning perspective, predictability is powerful to our earlier comments on financial toxicity. But as you mentioned, this year was the first true stress test on the pricing mechanics. Because in total, drug pricing doesn't live in a vacuum. So it's really interconnected through what I call the alphabet soup: AWP, WAC, AMP, 340B, and now you have MFP, which is the maximum fair price. So Medicare set a standard price on the 10 drugs. And you already mentioned one. Others are Enbrel, Imbruvica, Xarelto. And we've been watching manufacturers really respond in real time. So they had an opportunity to negotiate. And what we have seen now is different responses, adjusting distribution models, contract strategies, channel economics. And some of these changes are connected, within Medicare, where the focus is, but many aren't. And that's where commercial spillover comes in. So really, we're seeing a lot of ripple effects with the drug pricing in MFP. So it's where it gets operationally complex, for your viewers and those that are dispensing, especially in the specialty medication area. Um, so I'll just give a very common scenario that we're seeing right now. So a dispenser purchases a drug at WAC, which is the wholesaler acquisition cost. That dispenser is then reimbursed at the lower MFP rate and then needs to wait for a reconciliation payment through the Medicare transaction facilitator. So that payment is supposed to arrive in 14 days. We've already seen some variability in that. So layering on that Medicare transaction facilitator is paying a standard default refund amount. And what we've seen in the implementation of all of that is that rebate amount isn't a required field for the PBMs to respond when the dispenser is submitting their claim. So at the point of sale, there isn't always full visibility into the full economics. And so it really, would be nice to have confirmation of that rebate amount coming. But now some of that reconciliation is happening downstream. So from a margin in cash flow standpoint, that really matters. To take us back just a little bit and provide a parallel, there was a lot of conversations around DIR fees a few years ago and mandating that to be at the point of sale. We've arguably stepped backwards just a little bit, but as far as the point of sale goes, but the policy intent of the IRA is clear. It's just really the operational infrastructure is still maturing. So for dispensers, it's really not just having, compliance. It is also about having experts who live in this day to day. It's in this environment, I guess I'm trying to say, like, compliance alone isn't enough. You need strategy in order to be able to execute efficiently and be able to navigate all of the pricing constraints.
Yeah. I would just add that, unfortunately, patients are sort of getting caught in the chaos here. There is some confusion and, for, pharmacies and dispensaries to understand the economics, and it is causing, some patients to have to switch therapies or to switch their pharmacy services. So we are trying to help patients navigate that so that they are not experiencing gap in therapy and, no further confusion.
I really appreciate that explanation because to me, specialty drug pricing feels like alchemy, and you walked it through really nicely. So last question on the regulatory front, and then I'm curious to kind of get your views for 2026 and what we should be looking for. One of the things that stood out to me about the Rural Health Transformation Program was an increased focus on expanding scope of practice for pharmacists. This has been, from my time at SureScripts, an area that's really interested me. Pharmacists, it feels like, are maybe the most underutilized asset in the American healthcare. And so I'm curious if, for your views on that as pharmacists, but also whether there's any sort of implications for House RX on some of those things.
Yeah, it is really exciting. So in late December, CMS announced that there is $50 billion in awards going out to all 50 states. And so that was after an application process, and it's really the intent is to expand, not just, rules within the healthcare system, but also access to primary, maternal, behavioral emergency care. It's specifically focused on technology, innovation as well as the, healthcare workforce being expanded into rural health communities. So at HealthRx, that's extremely exciting. We have, both pharmacists and technology that can be empowered and used to reach, all patients that are in the U.S., no matter where you live. It is just a bit too soon to tell exactly how each state, they were going through their proposals, in which states are including first expansion to personnel and or an expansion to technology. But HealthRx is really hopeful that medically integrated dispensing will coincide with the expansions of these services and technology.
So we're just at the start of 2026. It's almost March. What should we be keeping an eye on from you all at House RX in terms of, expansion, expanded condition coverage, geographies, and then maybe more broadly, what does the landscape look like from your view for medically integrated dispensing and specialty pharmacy?
Yeah, I mean, at House RX, we've always believed that specialty pharmacy is best provided as part of this integrated medical care team. And so, what we'll continue to do is empower every community practice that we can. We believe that they should all offer specialty pharmacy services and that they should all dispense directly to their patients. And so, but there are headwinds to making that real. And so, we've spent a lot of time over the last 4 to 5 years of making this a really viable model in therapeutic areas other than oncology, right? Oncologists have been doing this for decades. When we started working with in the rheumatology space and started, asking our questions, why don't rheumatologists do this? They basically said we tried, we couldn't make the economics work. So we put in a lot of legwork to make this, not only better for patients and better for providers, but actually something that's economically viable and that will help to generate revenue for these practices. We want to keep community practices independent. We don't want them all to ultimately fold or to get acquired. So we've made great headway in rheumatology, and then we're going to continue to sort of expand our footprint because we believe that this should happen in every therapeutic area. Gastroenterology, neurology, dermatology, you name it, all of the ologies. We're going to continue to push and to serve patients everywhere that we can. We do believe that what we're really, really focused on is that in order to do this effectively, and Tamiko was just talking about this with the rural health initiatives, is you need good technology. Honestly, what has previously been on the market, we think is sort of antiquated, and just not effective to work in a sort of a multi-tenant environment, not effective for integration, right? Integration. When we say medically integrated, I've talked about, people being integrated into the practice, but we want our technology integrated with practice technology, with the EHRs being able to sort of seamlessly talk with the technologies that we're using. So we're really focused on continuing to develop that, and also to focus on, now that we have the basics, to really focus on, some innovation and automation. Obviously those are, huge buzzwords, and AI is everywhere, but so much of what it takes to do specialty pharmacy well is just monotonous and paperwork and just not value added. So everything that we can, automate, whether it's, waiting on hold and navigating phone trees, and I cannot tell you how many thousands of faxes we receive daily. So, we use AI to categorize and upload those so that I don't have to pay a human to do it. So, we're really focused on making the technology work for us and for our practices. That's what we're doing in 2026 for sure.
Thank you both so much for your time today. This was super informative, and we'll be keeping a close eye on everything that you've got going on with the medically integrated dispensing model. Thank you.
Well, thank you so much, Martin.